Good morning to our Honorable Founder and Emeritus Chairperson, Sir, Professor Dr. M.L. Swanka, Sir, esteemed senior faculty members, my colleagues and dear students. Before I proceed for today's critical care, this emergency medicine combined clinical round, I would like to take a moment to present a brief overview of my department. Our department was established in the year 2020 under the leadership of Emeritus Chairperson, Sir, with two students in the initial stage. This department was established with a clear vision and mission to provide excellence in emergency care with the blessings of the Sir. Our department has a very good state-of-the-art infrastructure provided under all these divisions. We have a dedicated neonatal resuscitation area, OBS emergency area, trauma emergencies, and routine all medical emergencies. With the state-of-the-art equipment and all the latest ones, these all enable us to perform a full spectrum of emergency procedures with precision and confidence, which we are performing day to day in this chaotic emergency room every day. Beyond these critical care, patients dealing, we are also performing the training programs like ATLS, ACLS, BLS courses, public awareness programs, and outreach activities to the nearby industrial areas to give them the BLS training, the trauma training, and the first aid training. We have managed a patient load of around 37,000 patients in last 2024 year with a total IPD of 11,000 patients, and with these, in these around 7,000 to 8,000 patients were of trauma care. And as our students are very well trained in all life support skill programs, I am proud to share that we achieve a return of spontaneous circulations which is being done, which has been achieved when we are performing the cardiopulmonary resuscitation, and it is around 18 to 20%, which is at par with the international benchmark of 21%. As the country was facing a possible war-like situations, So this is we performed CPR in around 120 patients, and out of which we attained this return of spontaneous circulation in 79% of the cases, which was around 66%, and out of which 56 were admitted to the ICUs and this cardiac care unit. So the survival to discharge, which was achieved, was around 18 to 20% from our department, and it is at par with the international benchmarks of 21%. This is all because of the trainings which our students are getting at our institutes, sir. So as the country stood on the brink of a possible war-like situations, emergency preparedness took the center stage across the institutes all over India. And so we at our institute also took a significant step forward to start with this mass casualty scenario mock drill, which was conducted on 13th of May 2025. In collaboration with the Department of Trauma, led by Dr. Jiten Mangtani, which was well coordinated by Dr. Avnish Katiyar, who is an MCH trauma surgeon, and in association with the other departments like critical care, orthopedics, general surgery, medicine, blood bank, anesthesia, and our department, we conducted this mock drill with the object to have the assessment of mass casualty response of our hospital and to identify the areas of the improvement, to strengthen our interdepartmental coordination with the other departments, and to optimize our resources best whenever we face such kind of situations. The strategy was to have these patients, after triaging them according to their priorities, like immediate life threats and potential life threats, to be prioritized in the red zone, which we are doing every day, then the yellow zone, which are of moderate injuries, and green zone, which were mild injuries. Then the simulated scenario was a bus accident which took place nearby Shivdaspura, and we catered around 10 casualties at that moment, and the outcomes were decided. Later on, I'll just discuss them.
What will you do, suppose, in a war-like situation which just has recent past gone?
Yes, sir.
What message you will give to our faculty, students and doctors working in the Mahatma Gandhi Hospital?
I would say that since we have prepared and we did a mock drill, we are at the best of this. This was a successful mock drill, and we are at the best of this. We are highly prepared for this whenever such kind of situations come, because we are provided with the state-of-the-art infrastructure, and we have all the best of the equipments.
I
So
mean,
we can.
that is all right, but just I wish to, or I want to tell all doctors working in the hospital and all the staff working in the hospital that luckily we have a basement,
Yes.
and more luckily we have 4 bunkers. So in case of threat, all our doctors, staff, they should go immediately to the basement, and if the further emergencies are there, they
Yes,
can take shelter in the bunkers. Stop all the
Routine
procedures,
procedures.
procedures, and utilize that opportunity. We are lucky that we have 4 bunkers and the full basement area measuring almost 96,000, you can say 1 lakh square meter of 1 lakh square feet, sorry, of basement, and immediately everybody should rush and save, apart from saving other things. Just to inform that we should be aware that we have basement,
And bunker.
and we are like in the RK block we have basement, and other places also we have basement.
Thank
you.
So this was the scenario. In first picture, we can see the patients were arrived, were ambulance in the approach, and from there these patients were taken to the triage area where the priorities were decided, and they were shifted to red, green and yellow and green zone. So we had 6 teams decided for 10 patients, and each team was having 3 doctors and 3 nursing staffs to scribe also and to call. And so before starting, we had informed our MD sir as a code yellow for this mock drill. So these are the red area zones where the patients were prioritized as per their needs, both in the first pictures. Then the yellow zone, which was led by Dr. Mantani sir, and the green zone led by Dr. Abhinay sir. After initial assessment and stabilization of all these trauma patients, as per the requirement, we advised their imagings. At the bedside, we did the X-rays of chest and pelvis, and once they are stabilized, we advanced them for the advanced imagings like CT, which we have in our area, and if required, before going for the CT, if the patients were hemodynamically unstable, they were immediately shifted to the emergency OT theaters only for the interventions. And lastly, we did a briefing for this. So this exercise was tested our ability to respond swiftly and efficiently. And now, this is a triage we have been doing regularly, the emergency severity index triage system. Nowadays we are using this, and they have different color zones. The immediate ones are to the resuscitate area, then to the emergent ones with the orange, then urgent, less urgent and non-urgent as per the priorities which are decided that how immediately you should address, 15 minutes, 30 minutes, 45 minutes and so on. Now with the brief introduction, I will proceed with today's clinical cases. We are all well versed with these monitors, and we are very happy to see these numbers with our patients. Especially, I am very happy because I am as an emergency physician. If I see these numbers, I feel that I am relaxed now, my patient is stable. But are these numbers always trusting for your patients? Let us see a spectrum of cases where these numbers lie to us, and we have to evaluate further with these patients. So I would like, there are 2 cases, the sleeper one and the blue paradox, which are giving us a different story seeing these monitors. So I would like to call upon my second year resident, Dr. Avniendra, to proceed with the first case.
What I am going to say doesn't apply to only your department, it applies to all departments. It is very good that we have huge amount of clinical data in a large number of departments, but unfortunately it is not translating into publications. So my request to all departments is that wherever there is a large amount of data, please give this as a thesis to your postgraduates. Now thesis is compulsory for postgraduates. MD or MS students can do retrospective data analysis also. For example, from your data, there are 2 articles which immediately come to my mind. What is the spectrum of trauma coming to a tertiary care hospital? That will help other hospitals which are starting an emergency service to plan what staffing, what equipment, what facilities have to be provided there, it can easily be published. Second, your conversion of into that return of resuscitation. So that analysis can easily be published. So my request to all departments, I have said this earlier, I am going to say it again and again. You may not like it, but that is my job.
Here I would like to add further that the data is the wealth in any department. If more the data you have, artificial intelligence work on what? On the data, algorithm of data only. So data collection, electronic medical recording, all these things are very, very important, not only in the Department of Emergency Medicine Department, all the departments. Have as much data as possible. That will be your wealth, that will be your strength, that will lead to the increase your research publications, increase in actual groundbreaking research also, and help in the focusing about what type of the diseases patterns are there, what type of the treatment can be there in our setup that can be documented with the help of artificial intelligence.
Sure.
So data is very, very important.
Just to mention that this is okay, but how many people have managed mass casualty? Everybody should know how to manage mass casualty. I was in charge of the surgery at the time of a bomb blast, and at that time truckloads of bodies and human beings were brought into the ICU. They were just dumped, not in the ICU, in the OP emergency.
Yes.
And we were wading in almost 2 inches of blood, and we didn't know which is a body, which is a human alive. So everybody should know how to manage such a mass casualty.
True. Thank you, sir. Dr. Avniendra, to proceed.
Thank you, ma'am. Good morning, everyone. I am Dr. Avniendra Bharadwaj from the Department of Emergency Medicine, second year resident, and I will be presenting you the first case of today's scenario. Our first case is a 30-year-old male, resident of Talk. He presented with complaints of headache, confusion, drowsiness since 3 hours on a chilly winter morning. His initial vitals were recorded, which were pulse of 99 beats per minute, blood pressure of 106 by 58 millimeters of mercury, and a oxygen saturation of 98% on room air. He was triaged in yellow, level 2. A quick primary survey in the form of ABCDE was conducted, in which his airway was patent, but the patient was as the patient was speaking a few sentences in dull voice. His oxygen saturation was 98% on room air, with respiratory rate of 24 breaths per minute, and bilateral air entry was equal. His blood pressure was 106 by 58 mmHg, and pulse was 99 beats per minute. He had a Glasgow Coma scale of 13 out of 15, E3, V4, M6. Patient was drowsy, but his pupil were 3 mm bilaterally reacting to light, and no neurological deficits were seen. His random blood sugar was 93 milligrams per deciliter. On exposure, the patient generalized flushing was seen. The patient was apparently asymptomatic 12 hours back. On a chiller winter night, he had gone to sleep in his car using Sigdi for warmth, and was found in a drowsy state by the police in the morning, and he was then rushed to a local primary health center, from where he got some treatment and some improvement in consciousness was reported. The informant was the brother of the patient, who was called by the police upon discovering the patient in the car. Therefore, a detailed history regarding the events and the complaints was limited. The patient reported generalized dull aching headache of insidious onset with a pain intensity rated at 3 out of 10. The confusion was noted at presentation. However, it was confirmed that the patient's baseline mental status was normal prior to leaving the home last night. Drowsiness was observed, but at the primary health center, he had regained partial consciousness and was noted to respond to verbal stimuli and follow simple commands as narrated by his brother. There was no history of vomiting, fever, neck stiffness, photophobia, blurring of vision, slurring of speech, focal neurological deficit, seizures, hallucinations, ingestion of any recreational drugs or substances, trauma, or complete loss of consciousness. In personal history, the patient is a chronic smoker, smoking 10 BDs per day for the past 15 years and occasionally consuming alcohol for 10 years. In general physical examination, generalized flushing was noted and a respiratory rate of 24, that is tachypnea, was seen. On CNS examination, the patient had a Glasgow Coma scale of 13 out of 15, E3, V4, M6. Pupils were reactive and there were no ptosis or nystagmus. Romberg's test for balance could not be assessed because the patient was drowsy. Symmetrical and normal deep tendon reflexes were noted all across the limbs and the meningeal signs were absent. In respiratory system, bilateral rhonchi were heard and other systems were normal. So after a complete history and physical examination, what should we be suspecting? Does an audience have any idea? The clinical possibilities are majorly categorized into three major headings. The first, the metabolic components, the structural and the toxins. In metabolic components, hypo or hyperglycemia, heat stroke, Wernicke's encephalopathy and sepsis would be the likely causes. In structural, cerebrovascular accidents or traumatic brain injury could be the likely possibility. In toxins, carbon monoxide, alcohol, sedative hypnotics, anticholinergics or salicylates could be the possibilities.
ऐसे सीनियरों में जहाँ पे सिगड़ी जली हुई है रात को, तो टॉक्सिक कार्बन मोनोऑक्साइड को पहले प्रायोरिटी दो, ठीक है?
Right. So to investigate further, a list of investigations were ordered in the emergency, in which his ECG showed normal sinus rhythm, his NCCT head was normal, chest X-ray was normal, and arterial blood gas was done. This is the report. Question to the audience. Can anybody tell me what do you infer from this ABG? The values are pH of 7.45, PCO2 of 52 and bicarbonate levels of 33.8. Anybody please? Sorry sir? Sir, but first what is the basic report of the ABG? That is there. Good find sir, that is, I appreciate it, thank you so much. Okay. With the said values, this ABG is suggestive of metabolic alkalosis because the bicarb levels, the pH, first of all, pH is on the alkalotic side and the bicarb levels are increased. Any other abnormality which sir has very well pointed out, the levels of carboxyhemoglobin. So to summarize, the ABG findings are suggestive of metabolic alkalosis and significantly raised carboxyhemoglobin levels of 22.5% seen in the oximetry values. Now it is important to acknowledge that such advanced oximetry values are not commonly available in standard ABG analyzers.
What is the normal met hemoglobin levels in the body?
Sir, normally it's up to 1, 0 to 1% they are present, met hemoglobin.
1 or 2?
1%. 1.
Up to 3%.
It is important to acknowledge that such advanced oximetry values are not commonly available in the standard ABG analyzers outside our institution. We are sincerely grateful for our institution for providing access to such state-of-the-art diagnostic systems.
You should not be grateful, you should be demanding.
Let's recapitulate what we have seen so far. A 30-year-old male, drowsy, found sleeping in his locked car with a Sigdi, presented with complaints of headache, confusion, drowsiness for the past 3 hours, and no history of ingestion of any recreational drugs or substances. Vitals were normal, and ABG revealed carboxyhemoglobin levels of 22.5%. So, from our list of likely possible clinical possibilities, the hypoglycemia and hyperglycemia are easily ruled out because the sugar was normal. The possibility of heat stroke remains unlikely because the weather conditions was wintry and the patient's temperature was normal. The structural causes altogether remain unlikely because this NCCT head of the patient was normal, and based on history and examination, the possibility of sedative and opioids, anticholinergics and salicylate remain less likely. So at this point, we made a provisional diagnosis of acute carbon monoxide poisoning. But now we must draw our attention to something puzzling. The patient's ABG oximetry value showed significantly reduced oxyhemoglobin levels with 76%, but SpO2 showing 95% on the monitor. Why is this discrepancy? To understand this paradox, we must first understand how the pulse oximeter works. So what is a pulse oximeter? It is a device which measures arterial oxygen saturation non-invasively using two light sources. This is the pulse oximeter, this is patient's finger. The two light emitting diodes emit red light and infrared light. The oxyhemoglobin absorbs greater amounts of infrared light and scatters red light, thus making the patient or giving the general appearance red to our eyes. On the other hand, deoxyhemoglobin absorbs more red light and reflects or scatters infrared light, which gives us the bluish purple appearance. To understand the mechanism, we plot different wavelengths on the x-axis and the light absorption on the y-axis. The standard pulse oximeter has two light emitting electrodes, diodes, which I have just shown you. One emits the red light and the second near red light, that near infrared light. Both of these work at their respective wavelengths, and this is the graph of oxyhemoglobin. We can see the maximum absorption is at the infrared light, and for deoxyhemoglobin the maximum absorption is at the red light. This is the normal functioning. But in case of carbon monoxide, there is an addition of another entity, the third entity, the carboxyhemoglobin, whose graph grows like this and which absorbs red light similar to oxyhemoglobin. So the standard pulse oximeter gets confused. So it cannot distinguish between the carboxyhemoglobin and oxyhemoglobin, thus making the saturation on the monitors normal.
How do you make oxygen saturation? What are the factors responsible for the oxygen saturation?
Sir, the biochemistry and physiological parts will be discussed.
What is the partial oxygen pressure?
Partial
oxygen pressure, which is directly related to the oxygen saturation.
Sir, it is the amount of oxygen which is dissolved in the blood, partial pressure of oxygen, PO2.
How much should be the partial pressure?
Sir, more than 80 to 100% it should be there.
80 to?
100%, PO2.
Pressure, I am talking about the pressure, not the saturation. Suppose आप केदारनाथ यात्रा पे चले गए,
right sir, 80 to 100,
एवरेस्ट पे चढ़ गए, लद्दाख में चले गए, नॉर्मल एटमॉस्फेरिक प्रेशर क्या होगा, ऑक्सीजन पार्शियल प्रेशर क्या होगा?
सर हाई एल्टीट्यूड पे रिड्यूस होता है प्रेशर,
रिड्यूस होता है ना, तो ऑक्सीजन सैचुरेशन उससे रिलेटेड है, कम हो जाता है.
Yes sir.
That is how you detect on the pulse oximetry also. These are the further fine things, all right? So that what is the normal atmospheric pressure?
Sir, 1 atm, 1
atmosphere.
760.
He is right. You can say 1 atmospheric pressure or
760 mm of water.
You should know all these things.
Yes,
These are the basic things. You are using pulse oximeter. Which fingers you should use?
So the index finger
Or
index finger.
You are in emergency department now. You are in the second year. COVID में कितना इन चीजों को सिखाया है?
Sir, basically pulse oximeter can be applied on any surface which is close to the.
नहीं, circulation सबसे ज़्यादा क्योंकि अपन use इन्हीं fingers को करते हैं. Either index finger or middle finger. ठीक है ना? You can use other fingers also if the circulation is good. All right?
Right.
और क्या पूछते हैं, जैसे कोई लेडी पेशेंट आ गई तो क्या पूछेंगे?
Nail polish.
कलर वगैरह का बहुत फर्क होता है.
जी सर.
They can also give you false reading.
Yes sir.
They can lie.
Yes sir.
Chalo.
So what is the solution? The solution is co-oximeter. What is co-oximetry? It is a device which measures 4 different wavelengths to measure the values of 4 different types of hemoglobins and the clinical conditions associated with it. Now that we have the answer to this question, to understand more about carbon monoxide poisoning, we must revise the structure of hemoglobin and its modifications, followed by the physiological aspects of gas exchange. And for that, I now invite to the stage Dr. Agrita.
If a patient has peripheral cyanosis, does it interfere with measurement of saturation by a pulse oximeter?
Sir, the standardization or the way in which this device is made, the healthy volunteers was used in making of this device. So in healthy volunteers, it can accurately reach up to 70% of oxygen, as low as 70. Below 70, as the saturation goes, the readings are not much reliable, sir, because the healthy volunteers.
Otherwise, also below 70 or 60, it is a cyanosis.
I'll call Dr.
Does the thickness of skin interfere?
Yes, sir. Yes, sir. The skin over the nail beds, the pulse oximeter can read in the places where blood capillaries are closer to the surface of the skin. So if we cannot get the readings on the fingers, we can also apply over the pinna. So the skin is thin over there. So the thickness matters, sir. Please, Dr. Agrita from Department of Biochemistry.
Thank you, Dr. Avniendra. Good morning, everyone. Now let's study about the structure of hemoglobin. So hemoglobin is a globular protein made up of 4 globin subunits, 2 alpha chains and 2 non-alpha chains, which can be beta, gamma or delta. Its diameter is 6.4 nanometer, molecular mass 64,500 dalton. So each globin chain are looped about itself to form a pocket or cleft in which the heme group lies. Each chain looped about itself to form a pocket or cleft in which heme group nestles, and inside each heme iron atom lies in ferrous form in divalent state, whether the hemoglobin is oxygenated and deoxygenated. Now the second structure is of heme. Heme structure contains a tetrapyrrole ring which is formed by joining 4 monopyrrole rings, each containing 4 carbon atoms and 1 nitrogen atom connected by methane bridges. Now modified hemoglobins. Modified hemoglobins are those whose structure has been environmentally or chemically modified, are called as modified hemoglobin. In carboxyhemoglobin, we see the attachment of carbon monoxide to hemoglobin, and sulfhemoglobin, we can see the attachment of sulfur to hemoglobin. The third one is methemoglobin. Methemoglobin is a form of hemoglobin where the iron in the heme group is oxidized from ferrous to ferric state, which prevents it from binding oxygen and carrying it to the tissues. This converts heme to hematin and
या तो 9:15 बजे तक आ जाओ, अदरवाइज मत आओ फिर हॉस्पिटल, ठीक?
and hemoglobin to methemoglobin, which unable to reversibly bind to oxygen and cause cyanosis. Now I would like to call Dr. Tushtika Vyas from Physiology department to explain physiological aspects of gas exchange.
डॉक्टर साहब, नॉर्मल हीमोग्लोबिन, फीटल हीमोग्लोबिन कितना होता है नॉर्मल एडल्ट?
So fetal hemoglobin,
कितना होता है?
sir,
यू आर इन बायोकेमिस्ट्री.
yes sir.
कैसे इलेक्ट्रोफोरेसिस करते
Sir,
हो?
we,
कैपिलरी इलेक्ट्रोफोरेसिस कैसे करती हो?
sir,
When you do the screening for thalassemia or sickle cell anemia
Yes, sir.
patient, how do you do the screening?
sir, in fetal hemoglobin, sir, are gamma 2 and 2 gamma chains and 2
Alpha chains,
alpha chains are
beta
present.
chains and gamma chains.
Yes,
Gamma
sir.
chains are in the fetal hemoglobin.
Yes, sir, fetal hemoglobin.
अगर
and-
fetal hemoglobin ज़्यादा है तो कौन सा thalassemia diagnose करोगे आप?
sir,
Any from the medical or clinical hematology department? तुम लोग यार बेसिक चीज़ों पे ध्यान नहीं देते और डेली का ये काम है. If the fetal hemoglobin is more in the blood, that indicates towards that he may be the carrier or she may be the carrier of beta thalassemia.
Beta thalassemia.
अभी
Sickle cell
thalassemia
disease.
day गया है ना?
जी सर, sickle cell disease.
चलो.
A very good morning to all. Now we will discuss about the physiological aspect of gaseous exchange. Gases which enters the body has to cross the alveolar respiratory membrane to reach up to the blood. This membrane is made up of 7 layers, starting from the surfactant layer, fluid and surfactant layer, then alveolar epithelium and basement membrane, followed by a thin interstitial space and 2 capillary layers, capillary endothelium and capillary basement membrane, and lastly the RBC membrane. Due to the pressure gradient changes,
Due to the pressure gradient changes, the oxygen diffuses from the alveoli to the capillary because of the pressure 104 mm of Hg to 40 mm of Hg, and carbon dioxide diffuses from the capillary to the alveoli because of the pressure changes of 46 mm of Hg in the capillary. But carbon monoxide, when present, also readily diffuses across the alveolar capillary membrane due to its high affinity for hemoglobin, which is more than 200 times of oxygen. So it rapidly binds to the hemoglobin, decreasing the partial pressure of carbon monoxide in blood. Now coming to the oxygen and carbon monoxide hemoglobin dissociation curve. Once the oxygen diffuses from lung, it is transported by the hemoglobin in the body. The curve shows partial pressure of oxygen at the x-axis and oxygen saturation of hemoglobin at y-axis. It is of sigmoid shape because when first oxygen compound binds with the hemoglobin, it increases its affinity for the another one. In the oxygen dissociation curve, partial pressure of 104 mm of Hg is required for hemoglobin saturation to reach 97%. Here we can also appreciate the P50 at which the hemoglobin is saturated. In the second graph of carbon monoxide, the main difference is that as low as 0.2 to 0.4 mm of Hg pressure is required for carbon monoxide to reach its maximum saturation. Here the carbon monoxide binds with the hemoglobin, decreases the oxygen carrying capacity, leading to severe anemic hypoxia. Coming to shifting of the oxygen hemoglobin curve. Shifting occurs to right when there is shift to the right signifies when the availability of oxygen to the tissues is more, there is unloading of oxygen due to increased oxygen release. The shift to right also occurs when there is increased temperature, decrease in the pH.
What are the diagnostic facilities or tests available to detect the right shift? And what are the conditions responsible for the right shift?
So right shift occur when carbon dioxide is more, so respiratory acidosis can be.
What are those conditions? Very common conditions are there.
High metabolic conditions.
अरे छोड़ो ना, pulmonary arterial hypertension नहीं हो जाएगा? Congenital heart disease, ventricular septic defects वगैरह नहीं आएंगे केस में? हैं? Am I right or wrong, doctor? How will you measure the oxygen in the vein, venous oxygen? You are mentioning the right shift.
Yes, sir.
How would you measure that? Is it pulmonary artery calcification? Is it regular feature in ICU? I think Dr. Ashish will better answer.
Yes, nowadays we are not using pulse, this Swan-Ganz catheter or pulmonary artery catheter, but initially yes, it is a catheter which we pass through the superior vena cava, goes to the right atrium, then right ventricle, passing through the this tricuspid wall and going into the pulmonary artery, and there we will measure a lot of things, not only this oxygen saturation, SVO2, SCVO2, as well as the cardiac output. Bit to bit variability in the cardiac output to responsiveness also can be measured with this cardiac index and measured with the pulmonary arterial catheter. Now, because of the availability of less invasive and non-invasive measurements or methods like LIDCO, PICO, and the thermodilution method, we are not using commonly, but in the CTVS ICU, yes, during the cardiac surgery, it is daily being used in the ICUs.
No, beta, when you are speaking, when you are presenting the slide, then
yes,
that anything. Anyway, chalo.
The shift to the left can occur due to decrease in the temperature and increase in the pH by the presence of modified hemoglobin like carboxyhemoglobin and fetal hemoglobin, which leads to decreased oxygen availability to the tissues. Role of oxygen and carbon monoxide in electron transport chain. When oxygen enters the cell, it acts as the last electron acceptor in the electron transport chain, which generates the ATP leading to aerobic respiration. But in the case of carbon monoxide, There is presence of ROS, that is reactive oxygen species, which blocks the ETC, and cell undergo anaerobic metabolism leading to anoxia and lactic acidosis, finally leading to cell death.
आपने कार्बन मोनोऑक्साइड का बोला है तो साइनाइड का भी बता देते हैं हाथों हाथ. साइनाइड पॉइजनिंग में क्या होता है? इज वेरी कॉमन.
ETC में ब्लॉक, दोनों में ही ETC का कॉम्प्लेक्स ब्लॉक हो जाता है. By the two mechanisms discussed, the anemic hypoxia and histotoxic hypoxia, leading to carbon monoxide manifestations in the body, leading to delayed neurological sequelae, personality and cognitive changes, leading to pulmonary edema, alveolar epithelium disruptions, myocardial injury and decreased cardiac output, gut inflammation, variation of microbiota, and anaerobic metabolism in muscles causes rhabdomyolysis. Now I would like to invite Dr. Avniendra Bharadwaja for the case progression.
Thank you, Dr. Tushtika. After revising our concepts of basic physiology and biochemistry, let's come back to our case. So far, we had made a provisional diagnosis of acute carbon monoxide poisoning. Now coming to the management, the strategy is definitive and supportive. Definitive treatment involves providing oxygen while maintaining the airway and supporting it with IV fluids, antibiotics and cardiac monitoring. In our case, we started the patient on high flow oxygen via non-rebreathable mask at 15 liters per minute. As we just studied, carbon monoxide binds to hemoglobin with greater affinity than oxygen, ultimately impairing its release at the tissues. High flow oxygen via NRBM at 15 liters achieves an inspired oxygen concentration near to 100%. And at these concentration, there is an increased partial pressure of oxygen in the blood, thereby competing with carbon monoxide for the binding sites on hemoglobin. This accelerates the dissociation of carbon monoxide from the hemoglobin, reducing its the half-life of carboxyhemoglobin from 4 to 6 hours on room air to 60 to 90% at 50 liters of at high flow oxygen.
How long you can give 100% oxygen?
Sorry, sir?
How long you can give 100% oxygen to the patient?
Sir, we have to monitor we have to do complete serial ECG.
What I wanted to know from you, what are the toxicity response related to the hyperoxygenation or too much saturation of oxygen? What toxicity can happen in the body?
Sir, sorry sir, I am not aware of this.
Anybody?
With a high concentration of oxygen, like 100% oxygen, we can give up to 20 hours, 18 to 20 hours. Otherwise, there will be lung toxicity will be there in the adult. While in the neonates, there can be little hyperplasia if you give the higher concentration of oxygen. Retinopathy.
The patient was kept on in the neonatal ICU on the ventilator, higher oxygen concentration. They develop the retinal problems, blindness and all other things. Okay? Apart from what Dr. Bhargav has said.
The supportive treatment of IV fluids and was initiated and Foley's catheterization was done.
What was the need for antibiotics?
Sir, patient, first of all, we admitted the patient in our emergency department, sir.
So what?
No, sir, patients, I'm telling, sir, the routine investigation.
This is a very common mistake in the exam. Question is asked and you are saying something else.
Sir, I was just coming to that.
No, not just.
Okay.
You have to answer the question straight away.
Okay. Sir,
question is why
आपको पता है कि कार्बन मोनोऑक्साइड पॉइजनिंग हुई है?
जी सर.
कोई इन्फेक्शन नहीं है, कोई सेप्सिस नहीं है, एंटीबायोटिक क्यों दी?
सर वो क्योंकि सर अभी पेशेंट का जो हमने काउंट्स कराए थे सर उसमें थोड़ा ल्यूकोसाइटोसिस आ रहा था जो उसमें
देयर आर सो मेनी थिंग्स.
हाँ सर. तो
प्रेगनेंसी में भी ल्यूकोसाइटोसिस हो जाती है तो क्या दे दोगे एंटीबायोटिक?
नहीं सर, प्रेगनेंसी.
There should be reason. Here you can say that we have done the Foley's catheterization, so maybe just to prevent the UTI, prophylaxis sort of things are given. That should not be given, but here you can answer like that.
Okay.
But what was the need for antibiotics? I would like to know from you or from your faculty.
So as we had done this invasive procedures to prevent that infection from the patient, antibiotics were started. And secondly, when we got the investigations, the patient has leukocytosis and he was also having infection in the urine. That is why we gave him. Plus, sir, a small patch was also there in the X-ray, and he had bilateral bronchi, and that is why we started. It was only given for 2 doses on the first day.
Sorry. On Foley's catheterization, we saw brown colored urine. So the patient was then admitted to our emergency department of emergency medicine, and routine investigations were sent in which CBC showed mild leukocytosis. The renal functions, liver function and serum electrolytes were normal. Urine report showed blood in urine. And for the brown, as the patient's urine was brown, we additionally sent serum creatine phosphokinase, which came out to be 3400 units per liter, which is markedly raised. And this suggests rhabdomyolysis secondary to hypoxia and carbon monoxide binding with myoglobin. So the definitive diagnosis of acute carbon monoxide poisoning with rhabdomyolysis was made. The patient was managed according to the standard fluid resuscitation protocol for rhabdomyolysis to avoid acute kidney injury. Initial therapy included 1 liter intravenous bolus of normal saline, followed by infusion at 1 liter for the next 2 hours, which was tapered to 500 ml for the next 6 hours, and the fluid was later adjusted to maintain the target urine output of 200 to 300 ml per hour. Following 24 hours of targeted management, the patient's blood gas parameter showed significant improvement with decreased carboxyhemoglobin levels to 0.4%, indicate a significant downward trend was seen in serum creatine kinase, phosphokinase levels from 3400 to 100, normalizing to 100 by day 3. The patient brown colored urine progressively cleared. This is a walk of patient's clinical progress. He presented with high saturation but had carboxyhemoglobin levels of 22.5%. Brown urine and raised CPK pointed towards rhabdomyolysis. With treatment, carboxyhemoglobin levels dropped, urine cleared, and CPK normalized. Full recovery was achieved by day 4. At 1 month follow-up, the patient remained asymptomatic and neurologically intact. This was about the first case, and for the second case, I would now like to call upon Dr. Ankita. Simple fluid IV, sir, with large bore cannula. So because the patient was very comfortable, there was no other abnormality which we could detect in the...
Was getting 300 ml per hour urine.
Yes, sir.
Was getting suppose he got it off.
Yeah, but we were not using, we didn't give him diuretic because he was pouring large amounts of urine, and there was no clinical picture suggesting of pulmonary edema or fluid overload in the patient.
Bronchitis?
Sir, the bronchi were there from the very previous, before giving the fluids also, because he's a chronic smoker for past 15 years. What we said. But there were no preps or...
Then again, if I say if he is a chronic smoker, then the possibility of COPD as well as right-sided failure because of the core formula is much higher. Then we should give some diuretic as well when we are giving such large volumes.
We were ready to give diuretics, but it was not required. The patient's output was adequate. The input-output charting was monitored, and it was all adequate, so we didn't. Otherwise, we would have given, sure, we would have given diuretics if required. Yes, sir? No, sir, no role of Sodavecca.
Already alcohol substitute.
Good morning, esteemed dignitaries and my enthusiastic audience. The blue paradox will be the second case in a series of 2 shades of silent hypoxia today. A 24-year-old male student and a resident of Sanganer, Jaipur, presented in emergency room with the complaints of vomiting, headache, shortness of breath that he developed 5 hours back. Vitals were recorded. Pulse rate was 113 beats per minute. Blood pressure was 120 by 72 millimeters of mercury. and oxygen saturation, being a red flag, was 81% at room air. Accordingly, the patient was triaged in red category level 1. As per ER norms, a primary survey was done. The airway was patent, bilateral air entry equal, respiratory rate 26 per minute, and oxygen saturation of 81% at room air, for which oxygen was provided by face mask at 8 liters per minute. Blood pressure was again 120 by 72 millimeters of mercury, and pulse rate was 113 beats per minute. GCS was 15 by 15 with pupil 3 mm reactive to light and no neurological deficits. Random blood sugar was 124 milligrams per deciliter. On exposure, central and peripheral cyanosis was present, seen on tongue, palms, and nail beds. Patient was apparently asymptomatic 5 hours back. There is a history of intake of foods and beverages at a wedding the night before, and patient developed 3 episodes of vomiting which were non-projectile and non-bilious, generalized headache of insidious origin with a pain score of 3 by 10, and shortness of breath which was insidious on onset, non-progressive, and aggravates on climbing a few stairs. All these symptoms developed in 5 hours. Negative history was taken. No history of chest pain, anxiousness, sweating, cough, pain abdomen, photophobia, fever, neck stiffness, and blurring of vision. Past history, personal history, and family history were not significant. On general physical examination, central and peripheral cyanosis was present, respiratory rate was 26 per minute, and oxygen saturation was still 81% on oxygen, 8 liters per minute. Therefore,
can you tell me the causes of central cyanosis as well as causes of peripheral cyanosis?
Yes, so central cyanosis, it is mostly hypoxemia in which a patient may be in shock due to major blood loss, or patient can be at high altitude. In peripheral cyanosis, because of peripheral vascular diseases or some, so peripheral cyanosis, so DVT, deep vein thrombosis, commonest.
बीड़ी सिगरेट बहुत पीते हैं, रेनॉल्ड्स डिजीज नहीं होती क्या?
रेनॉल्ड्स डिजीज
कॉमन चीज याद रखा करो.
As saturation was still 81% on oxygen 8 liters per minute at 10 minutes in the ER, on 10 minutes in the ER, we increased oxygen supply to 15 liters per minute via NRBM mask. Systemic examination was within normal limits. To summarize, a 24-year-old male, history of consuming food at a wedding the night before, presented with complaints of vomiting, headache, shortness of breath since 5 hours with central and peripheral cyanosis present. Can somebody enumerate the list of differential diagnosis at this point? Clinical possibilities were categorized into 3 categories. Under the category of respiration, pneumonia and pulmonary embolism looked likely. Under the toxins, methemoglobinemia or any drug exposure. For cardiovascular, congenital heart diseases was most probable. Investigations were done in the ER itself. On ECG, sinus tachycardia was present. In echocardiography, the parasternal long axis view showed no abnormality. It was within normal limits. The 4-chamber view was also normal. As we can see, there is no shunting seen across the septum. Chest X-ray was also normal. This is the sample taken for arterial blood gas analysis. Any uniqueness seen with it? Thank you, sir.
This is the characteristic feature of hemoglobin.
Chocolate brown blood sample was withdrawn. When the blood was withdrawn, it was chocolate brown in color. This is the first arterial blood gas analysis report in ER with pH 7.4, PCO2 32.3 and bicarb 24.9. A diagnosis of respiratory alkalosis was made. Methemoglobin levels of 49.4%, which is abnormally increased 30 times the normal value, and oxyhemoglobin of 50.7%. Now, as per the findings seen, as per the evidence seen,
क्या खाया था? Did you take the history in detail.
Yes, sir, it is there, but it is allegedly reported, so we have not documented it.
Which were around 10 to 15 in number, with ice used from the local area.
Was he only affected or some of other
As
people?
we took detailed history, but he said मुझे ही हुआ है and I
बाकी
do
और
not know about the
और
others.
लोग जिन खाना खाया तो उन्हें किसी को कोई प्रॉब्लम नहीं
सर
हुई।
औरों का नहीं पता।
ठीक।
As chest X-ray was normal, pneumonia can be unlikely. As echo was normal, pulmonary embolism and congenital heart diseases also become unlikely. As there is no history of drug intake or exposure to dyes, drugs can also be ruled out. Now, a provisional diagnosis of methemoglobinemia is made in the ER. Patient was admitted under Department of Emergency Medicine and routine labs were sent. Complete blood count, renal function test, liver function test, serum electrolytes were all within normal limits. As G6PD patients are also prone to methemoglobinemia more, so a qualitative sample of G6PD was sent, which again came back to be normal. Now I'd like to invite Dr. Agrita, my colleague from Department of Biochemistry, to enlighten us on the biochemical aspects of methemoglobin.
Thank you, Dr. Ankita. Now let's learn about the pathways for the reduction of methemoglobin. Normally in our body, iron in hemoglobin is present in ferrous form. Due to oxidation stress, about 0.5 to 3% of hemoglobin is converted to ferric form, which is called methemoglobin. It is converted back to ferrous form by cytochrome B5 reductase enzyme by using NADH. During methemoglobinemia, iron is oxidized to ferric form. Here we use methylene blue, which uses NADPH to convert ferric to ferrous form. NADPH is generated through the hexose monophosphate shunt pathway, in which glucose 6-phosphate dehydrogenase enzyme is essential. So there are three pathways for the reduction of methemoglobin: primary, alternative pathway, and other pathways in which ascorbic acid is required. Now, analysis of methemoglobin. Each of the modified hemoglobin has a characteristic spectral pattern analyzed by blood gas analyzer and co-oximeters. Now, the methemoglobin levels: 1 to 2% of methemoglobin is normal. After 10% of methemoglobin, symptoms start appearing like skin discoloration in mucous membrane, and at about 30 to 50% methemoglobin concentration, symptoms like confusion, dizziness and tachypnea, which was seen in our patients. Now I would like to call Dr. Ankita to continue with the case solution.
Thank you, Dr. Agrita. Now to summarize, a 24-year-old male presented with complaints of vomiting, headache and shortness of breath since 5 hours with a history of consuming food at a wedding the night before. Patient presented with central and peripheral cyanosis. Blood sample was chocolate brown in color. On arterial blood gas analysis, methemoglobin levels were 49.4% and oxyhemoglobin level 50.7%. A provisional diagnosis of methemoglobinemia was made in the ER and patient was admitted. Now, we being as curious physicians, why was the SpO2 not improving with oxygen therapy? My colleague Dr. Avniendra has already enlightened us on the topic, but just to highlight a few points. Normally the pulse ox reads oxyhemoglobin and deoxyhemoglobin, but in this pathology there are three entities, also the methemoglobin. Now methemoglobin absorbs both red and infrared light equally. The ratio comes out to be 1 in the case of methemoglobin, which corresponds to oxygen saturation on pulse ox being 80 to 85%. Therefore, no matter how much oxygen we give to the patient, it will still read 80 to 85%. Now, to manage the patient, along with the supportive treatment of fluid resuscitation and oxygen therapy, the antidote, which is methylene blue and also commercially available in our institution, was given to the patient. The mechanics of it have been explained by my colleague Dr. Agrita. The dosing of 1 mg per kg IV over 5 minutes was given. 60 mg was given to our patient as per his body weight. Oxygen via an RBM mask at 15 liters per minute, which increases oxygen delivery to tissues, enhances the natural degradation of methemoglobin. Intravenous fluids and urine output monitoring was done. After 2 hours, these changes are seen in the presentation of cyanosis.
कौन सा चीज आई खाने में जो इस पेशेंट को मेथेमोग्लोबिन? वी शुड थिंक अबाउट स्पिनच।
वाटर है जो वेल वाटर है जिससे उन्होंने आइस बनाया होगा, दैट कुड बी टॉक्सिक।
बाकी लोगों तो शादी में आए थे, बाकी के लोगों को भी तो होना चाहिए था।
So maybe because he took it in a larger amount than the conventional.
10 to 15 glasses of that shake and बहुत सारा पकौड़ा। हमने उसको बार-बार इसलिए पूछा है क्या खाया है तुमने, ऐसा हुआ।
चलो ठीक। Just on a very practical side, because nowadays we are wearing this electronic watch which gives the oxygen saturation also and heart rate and EEG also whenever you want to take EEG, but heart rate and oxygen saturation is all the time coming. Sometimes I myself see that my oxygen saturation is 82%, 86%. What does that signify? I get alarmed when I do with the pulse oximeter, then it comes to 99 and 98%. What is the? Have you other those who are wearing these watches have noted? Eh?
Actually, the algorithm is not the algorithm for these watches and the mobile. For calculating the pulse oximeter saturation is not as good as the normal pulse oximeter algorithm. Because this is based on the algorithm according to the value which they are capturing. So still, sir, in the literature also there are many papers present whether we should use these gadgets calculation in the clinical preview. So they say we should wait, we should not use these things. It is just for, okay, there is some problem, consult a doctor or a paramedic to get the real.
Suppose आप किसी पार्टी में से आए और सोगर सुबह देखा 86% भी रहा है आपका saturation, but morning में तो आप ठीक लग रहे हो.
Sir, we should check with the normal, the standard pulse oximeter, sir, rather than believing on the AI-based system.
So don't get panic, no. I have experienced it many times, to be very honest, and initially I was little bit anxious, but now I realize that no, this is the best method.
Sir, in COVID also a lot of patients came to us having the data from the watches, Apple watches and the mobile phones, that I have low saturation, I have fever, then they start panicking, I am getting COVID.
Yes, anybody can get panic if they are not having proper
so at those times, sir, these all papers came in.
So what message for all of us is that we should not rely on one particular instrument and recheck it, no?
Now, after 6 hours, green colored urine was seen in the Eurobags. Can someone tell me the other findings where we can find green colored urine? Apart from that. Methylene blue was given to the patient, which is blue in color. Its metabolite comes to be leukomethylene blue, that is excreted in urine. Urine already contains urochrome, which is yellow in color. Two primary colors constitute to a secondary color, that is green. Serial ABGs were done.
मैं एक बात बताना चाहूँगा कि भगवान कृष्ण का कलर है नीला, ब्लू ह्यू, और भगवान राम का जो कलर है वो है ग्रीन ह्यू. हैं दोनों ब्लू बट ग्रीन ह्यू है. सीता जी बहुत गोरी थी, वन ऑफ द मोस्ट ब्यूटीफुल लेडी ऑन द अर्थ एज ए अवतार, ठीक है ना. और उसका जो येलो था, आभा जो थी उसकी, वो भगवान राम के ब्लू कलर पे पड़ती थी, तो ग्रीन कलर राम जी का हो गया था. So there is difference in the shade of Lord Ram and Lord Krishna. Lord Krishna was blue because राधा जी बहुत साल साथ नहीं थी, बचपन में साथ रही, रुक्मणी वगैरह आ गई थी बाद में. बट भगवान राम के एक ही पत्नी थी, तो वो ह्यू उनके पास हमेशा रही. एंड इट इज in the Bhagavad also and in Valmiki Ramayana also, that his hue was green tinge. Of course, Shantakaram Bhujaksenam Padmanabham Swarisam, उनका जो ह्यू है वो आकाश की तरह ही है, मतलब मेन कलर, ठीक है ना. बट बिकॉज ऑफ मिक्सिंग ऑफ green color with yellow color, blue color with yellow color leads to the little bit of green shades. Just on lighter note, and for the knowledge also.
So there is one more entity which can cause the green color
propofol infusion.
Anesthesia patients, like students who are there. So remember, if you are giving infusions of propofol, if there is toxicity, then it can produce green color urine also.
Serial ABGs were done on the time of presentation. Methemoglobin levels were 49.4%. After 30 minutes, reduced to 40%. After 2 hours, to 4%. Now to the disposition. At the time of arrival, methemoglobin levels were 49% and methylene blue was given. At the time of admission, cyanosis was resolved and methemoglobin was reduced to 4%. Patient was admitted and observed for 2 days. On day 3, patient was discharged and referred to hematology OPD for further workup. Now I would like to invite Dr. Avniendra to discuss and conclude the 2 hypoxia.
Thank you, Dr. Ankita. We have now seen the 2 shades of silent hypoxia, and now let's see the contrasting features between them. In case first, we encountered a patient who appeared red and drowsy. His saturation was 98%, very reassuring, but clinically something did not add up. Given the limited history involving the prolonged exposure in smoke in a confined space, a diagnosis of carbon monoxide poisoning was made. ABG was suggestive of carboxyhemoglobin levels of 22.5%, dangerously elevated, and timely high flow oxygen and supportive care helped him reach a full recovery by day 4. In contrast, the case in our second case, he presented with the opposite scenario, in where he looked blue and visibly cyanotic, yet appeared far more comfortable than his oxygen saturation of 81% would suggest. Even on high flow oxygen, the saturation did not improve. This clinical paradox, low saturation, stable patient, prompted us to consider methemoglobinemia. The ABG confirmed it. A single dose of methylene blue led to dramatic clinical improvement and recovery within hours. These are a few case reports. The first one is a woman of 28% burns in an enclosed space developed carbon monoxide poisoning leading to rhabdomyolysis. The key feature is carbon monoxide poisoning can precipitate severe muscle breakdown and renal complications, as was seen in our patient. A 32-year-old woman developed rhabdomyolysis after CO poisoning, and the key highlight being she developed delayed neurological outbursts. This underscores the importance of long-term follow-up. A third case of a child who developed severe methemoglobinemia of 62% levels of methemoglobin. This demonstrates the risk of nitrate accumulation in stored vegetables, leading to methemoglobinemia. Sir, these are green leafy vegetables of broccoli and cauliflower, spinach also. To conclude, the 2 cases reflect the culmination of clinical vigilance and diagnostic clarity and timely intervention in the face of misleading numbers, which could have easily been looked upon. But with proper management, all the red flags were identified, the subtle red flags were identified, and the blood gas confirmed with their co-oximetry values. The true identity was relieved. And for that, we again owe our deep gratitude to our institution leadership, whose continued investment in advanced point-of-care diagnostics like bedside ABG with oximeters makes such timely and accurate care possible. Without these tools, both cases might have been misdiagnosed or worse, missed altogether. And last, we humbly thank the management of Mahatma Gandhi Institute of Medical Sciences for all the state-of-the-art infrastructure they have provided, the CCR review committee for their valuable guidance at all times.
Everything is provided, excellent presentations, but please request all the residents to develop a habit of analytical mind. and always keep your mind open from all sides. Have a three-dimensional approach to any problem and focus on the basics. You will remember for more time, you will diagnose better. ठीक है? रटंत विद्या नहीं लगानी है. रटना जरूरी है, पर पहले बेसिक्स को क्लियर करो, फिर बार बार you should read it again and again. ठीक है?
Yes.
Do you know of the book Coma by Robin Cook? Robin Cook. Coma.
Sorry, sir, I'm not aware.
Very related to this topic.
Okay, sir.
हमारे ज़माने में डेटा इकट्ठा नहीं होता था, नहीं रोजाना सर्दियों के टाइम में सिगड़ी जला के लोग सो जाते थे, केरोसिन की वो लालटेन जला के सो जाते थे और बहुत पेशेंट सुबह मरते थे. We have not collected data. Otherwise, you can publish a series of.
Thank you.
That book was a bestseller,
Right.
and a movie also has been made on it, where they used to give CO2, and CO2 poisoning could not be detected in the postmortem, and they used to take out the kidneys and all those things.
Okay.
So that was a bestseller. You should know book Coma.
Sir, just wanted to thank the collaborating departments, the patients without whom this discussion would have not been possible, the supporting staff and the technicians from the emergency department, and most importantly the audience for listening to it. Thank you so much. And salute to our Indian Army, because they have very well taken care of us in these very tense times. We are easily living our lives, so special mention to the Army. Also, the World Emergency Day is coming on May 27th, which will, some events would be organized where ma'am will.
So remember that we have basement and 4 bunkers. पता नहीं पड़ता लाइफ में क्या सिचुएशन आ जाए. अगर आपके पास फैसिलिटीज हैं तो जिसकी भी जान बच जाए, और जहाँ तक न्यूक्लियर अटैक का सवाल है तो अगर आप बंकर में चले गए तो बच ही जाओगे. टाइम में 24 आवर्स निकाल दो, उसके बाद रेडिएशन के इफेक्ट्स कम होने लग जाते हैं.
सुचिता, आपको कुछ कहना है? I have a pleasant announcement. May I request Dr. Yash to come here? Dr. Yash Katot, he did his MD in internal medicine from SN Medical College, Jaipur, and then did his DM in infectious diseases from the prestigious AIMS, Jaipur. He has joined us as a consultant and assistant professor in infectious diseases. I welcome Dr. Yash to the institution, and I expect that he will coordinate the activities between general medicine, pediatrics, intensive care, microbiology, oncology, and various other departments, because infectious diseases are becoming more and more important. Would you like to say something about infectious diseases?
Thank you for the kind introduction, sir, and I am honored and delighted to be here, part of this institution, and thank the management and Chancellor, sir, for having me on board. It is an emerging branch and quite neglected one in India. We have seen the examples here in the presentation today. The thing is, our wisdom is like most commonly will be utilized by the department which deals with the patient who are at high risk of infectious diseases, as oncology or transplant setups. But its scope is not limited to just that. Even the community acquired infections, common one, which are actually not managed properly or not responding to the therapy, like recurrent UTI and all. Nosocomial infections like ICU infections related to HAP-VAP, CRBSI, invasive candidiasis, all those things might need our input, and we can help streamline the treatment for the better outcome, and can individualize the therapy for the patient based on their PK/PD and patient dependent factors. I hope that I will be of some help to you, and I'm thankful again to everyone here.